It is kind of a dreary day outside. Yesterday I was actually in sunny Southern California. The American Epilepsy Society meeting was last weekend in San Diego, so I was out there for a few days, and my wife came with me, and so we took a few days afterwards and went up to LA and spent some time with her brother-in-law. And for the first time I went out to Venice Beach. So I don't know if any of you have ever been to Venice Beach, but it's an interesting place, and the very first thing I saw when we walked onto the boardwalk, very first thing I saw when we walked on the boardwalk was this. So if you notice, this is notice the interesting herbal remedy that they have outlined here. I thought this was shocking. And so these guys have a walk-in clinic. I was talking, they have a hawker on the street who's trying to get folks in. It's a 15-minute appointment, $250. They don't take insurance. And they only write prescriptions for one thing. But they treat all kinds of maladies. It was impressive. So I know with the looming fiscal cliff and the healthcare bubble that we all fear may burst any year, I guess it's good to know we have options as healthcare providers. Though I don't see myself taking advantage of this any more than I see myself going back to go to law school and become a lawyer or anything like that. So anyway, so I thought that was interesting. I'm going to be talking to you a little bit this morning about, initially about diagnosis and classifications of seizures and how we approach that, and some interesting videos of some of the more tricky things that we see that relatively commonly, and then after that I'll be talking a little bit about epilepsy drugs. Okay, so the basic workup of seizures. I think we're all familiar with this, but I'll just go over it again so we're all on the same page. So the first and foremost thing that you need to get in helping to diagnose somebody's spells or seizures is a detailed history. Sorry, that's a little bit better. So I can't emphasize enough how important that is. Each of these things should be documented and can be very informative. And I can't tell you how often when I'm seeing patients in clinic that are refractory patients who are being seen by the third physician, how often it's one key detail of history that upon which the diagnosis may rest. So age of onset is important, frequency, how often the seizures happen, do they have an aura, which often gives an indication of where the seizures are coming from, what part of the brain is involved, whether it's partial or generalized. The initial ictal behavior, then how does it progress? I always insist that the family member do the best that they can to tell me not just what happens in the spells, but what's the first thing that happens in the spell, what's the next thing that happens in the spell, what's the next thing that happens in the spell, and try to push them as hard as possible to give me those details. The duration of the spell is important. Most epileptic seizures last only a few minutes, and so if a spell goes on and on for a long period of time, that may suggest that it might be another etiology. What is their post-ictal behavior, or do they have a lack of post-ictal behavior? Which also may point you in a certain direction towards certain types of seizures. Are there other associated symptoms such as tongue biting, loss of bladder control, things like that? What is the timing? Do these things only happen out of sleep? Do they have certain triggers such as certain reflex epilepsies? Are they triggered by stress, that sort of thing? What's the association of the spells with medication changes? Do these things only happen after somebody has only happened 3 times and always 2 days after their Klonopin was withdrawn? And what risk factors do they have? They have a history of traumatic brain injury, perinatal injury, and also just psychosocial risk factors that may predispose them to non-epileptic spells. So again, this is really the mainstay and the most important thing in making a good quality diagnosis. And as I said, when patients are in for a tertiary referral, this is what we go back to, and this is probably the highest yield thing that we do. So then the other basic part of the workup is imaging. MRI is preferred. CT is can be valuable too, particularly in the acute setting, but MRI really is the standard of what you want to get. And then an EEG, routine or sleep-deprived EEG. Sleep-deprived EEGs are a little more helpful for generalized epilepsies, and they're also helpful for partial epilepsies because the patient may go to sleep, which may give you a little bit different expression of interictal activity. So why do we do this workup? I think everyone learns that in their first month of neurology residency that somebody comes in with seizures, EEG, and MRI are part of the workup. But why do we do that, especially since a lot of times we can base most of the stuff in the management on the history? Well, from an imaging standpoint, you want to rule out a serious lesion. You want to make sure this patient doesn't have a brain tumor, a hemorrhage, a recent stroke. You also, if you see an abnormality, it may indicate treatment after just one seizure. As you may know, only about half or 1/3 of patients who have a single seizure will ever go on to have a second seizure. But if you see an abnormality on imaging, then we will go ahead and treat even after they've only had one seizure. Furthermore, the findings may support a diagnosis that's otherwise unclear. So a patient comes in with funny sounding spells, you're not sure if they're epileptic or not, but then you do an MRI and you see that they have a cavernous malformation or something like that. You know, okay, these things probably are seizures, even though I can't say that definitively on clinical grounds. And then you also may identify a surgical target with this, which is good for figuring out what your therapeutic options are and discussing that early with the patient. Lastly, it can help you with prognosis. So about 70% of patients with epilepsy will be well controlled on one of the first two medications that they try. But if you find a lesion such as hippocampal sclerosis, which is the most common imaging abnormality in temporal lobe epilepsy, then you know that even if they are drug naive and have never failed a drug, they only have about an 11% chance of being seizure-free on medications. It helps you advise the patient in that way. So what do we look for in EEG? Well, some of the same things. We are looking for an abnormality. If you see something abnormal, whether it be an epileptiform abnormality or simply slowing or a focal abnormality, it may indicate treatment after even just one seizure, indicating the patient is very likely to go on to have another seizure, and you can make the diagnosis of epilepsy. It may confirm the diagnosis also if you're otherwise uncertain. So again, if somebody has funny looking spells that you're not sure epileptic or not, and you get an EEG that shows an epileptiform abnormality, then you can be more confident that this is in fact epileptic in nature. It may also help you classify their epilepsy as either a partial or generalized epilepsy, which is the major branching point in terms of pharmacologic treatment of epilepsy. So there's a certain class of drugs that seem to work better for partial epilepsies and are not indicated for generalized epilepsies and vice versa. All right, so that's the basic workup. But what do we do for the more challenging cases that need some secondary workup or additional workup? Well, an ambulatory EEG may be useful. It has some specific utilities. Specifically, it may show interictal spikes that are not seen on a routine EEG. So some people only have seizures only have interictal spikes when they go to sleep. And so a 30-minute sample on a routine EEG may not give you much of a window into their interictal activity. Some people may have spikes as few as 1 or 2 every 2 hours. So getting an ambulatory EEG, a 24-hour or 48-hour EEG may reveal interictal abnormalities that aren't seen in a short window. It also may confirm the resolution or control of absent seizures. This is one of the more common indications for ambulatory EEG. Somebody doesn't report having seizures, but you want to make sure before they're ready to drive that their absent seizures really are under control and have ceased, which otherwise may go unobserved, even with attentive family members. The big downside of ambulatory EEG, though, is that there's no video. And really, video is virtually essential, almost essential in the evaluation of somebody's seizures. It's a very, very important component of it, and adds, I would argue, just as much information as looking at the brainwave activity. So really, inpatient video EEG is, in my mind, preferable in most cases for the next step after the basic workup. We did a study a few years ago at UAB and found that 82% of our admissions are diagnostic on the first admission. So it is quite useful. It's very, very useful if the seizures are frequent. If somebody has spells 1 or more times a week, you have a high likelihood of capturing one of their spells while they're in for a 3 or 4 or 5 day admission. But even if they have infrequent seizures, we can a lot of times are able to capture a spell by withdrawing their medications, which may increase the frequency of their spells, or doing other activating procedures such as sleep deprivation and photostimulation. And even if they don't have spells while in the hospital, again, you have an opportunity to observe their interictal record and see if there's evidence, interictal evidence of epilepsy. One thing that in the last few years has become very useful, and I've taken a great advantage of this, is that just about everybody's cell phone now has video on it. And so I tell patients' family members that one of the best things they can do after they make sure that the patient is safe is pull out their phone and capture some video of it. A lot of times, I would say probably about 80% or 90% of the time, I can make a diagnosis based purely on the video alone and looking at the clinical semiology of what the patient is doing. I even had one very motivated patient who lived alone and only had spells in his sleep. And one spent a night at his father's house, and his father said he heard noises coming from his bedroom and was wondering if he was having seizures. And so what I suggested to him was that he go and get a camcorder, which he already had from his sister, and set it up in his bedroom. It was one of these ones that records to a flash drive or hard drive or something like that, so it could record for 8 hours. Just told him to set it up and record himself as he slept every night until he captured a spell. Sure enough, the first night he had 3 seizures and was able to bring that into clinic, and these things that we were very uncertain about, uncertain of the frequency, we were able to confirm that it was actually a diagnosis of frontal lobe epilepsy. So video alone really can be very helpful, and I'll show you some examples here in a couple minutes of seizures where the EEG was negative, but the video really made the diagnosis. So this is what we see at the UAB EMU. As you can see, and this is our real data from about the last 10 years. I pulled this out of our database last week. And so you can see temporal lobe epilepsy, TLE, is the most common syndrome of epilepsy in adults. So that's the single biggest pie wedge of the epilepsy side of things. And it accounts for about 21%. Another 3% have what we would call TLE plus, which is somebody who has apparently predominantly temporal lobe epilepsy, but also has seizures that may spread to other regions, or it may be ambiguous as to whether it's starting in the temporal lobe or the adjacent frontal lobe. 15% of patients have of the admissions have extra temporal lobe epilepsy. So since so much of adult epilepsy is temporal lobe epilepsy, we really lump patients into the temporal lobe group and the non-temporal lobe group. About 7% have generalized epilepsy. Usually those are easier diagnoses and a lot of times don't make it to the epilepsy monitoring unit or don't require that. Then about 33%, I was surprised actually that this was this low, but 33% have psychogenic non-epileptic spells. I could tell you sometimes it feels like 100% have psychogenic non-epileptic spells, but that is an important and valuable part of what we do and a very, very legitimate use of the epilepsy monitoring unit. These people are a very important patient population who often don't get the care that they really need. And it's very valuable to make a definitive diagnosis and get them referred on to somebody who is a specialist in giving them the psychological care that they need. And then about 21% of the admissions are negative. So we know sometimes, even if somebody does have epilepsy, we have a negative study, they sit there for days, have no interictal discharges, and really about 50% of patients with epilepsy will have no interictal discharges, even if they perhaps have rip-roaring seizures and have very, very bad epilepsy. So, so sometimes we don't get a diagnosis. So taking out this piece of the wedge here, which is in many ways one of the more interesting parts of it, we could break out the extratemporal lobe epilepsy into several parts. And you can see that frontal lobe epilepsy accounts for 55% of this pie wedge. Then definite parietal lobe epilepsy was only 6%. Definite occipital lobe epilepsy was only 5%. And then this other sort of approximately 1/3 of it was either multifocal or not well localized epilepsy. So sometimes even if you see a whole bunch of seizures, the exact localization may not be clear. It really is a network disease, and sometimes that network is quite wide. So I imagine that actually the incidence of occipital lobe epilepsy and parietal lobe epilepsy is much larger than these percents, but they get buried in here and may not be differentiated. So I'm going to spend a little more time in a few minutes here talking a little bit about frontal lobe epilepsy a little bit more. So, but like I said, temporal lobe epilepsy is the most common thing we see. This is, I think, something we've all seen. So this is a classic frontal temporal lobe seizure. The patient is actually, at this point, talking intelligibly, though it's hard to hear. Then now goes into his spell. He's having these sort of guttural sounds, and it gets quiet. And if you look now, you can see he's starting to do some lip pursing and some automatic movements. So classic temporal lobe seizure. The nurse comes in. I'll let you just watch, and we'll go through it again in detail. That was the family member he was on the phone with, calling back.
Touch your nose for me. Tell me your name.
All right, so let's do this. What I'd like to do is just go back and we'll look at it again, and I'll stop it and start it and just kind of point out a couple things. So again, here it's hard to hear, but he actually is making sense. And then he pauses, and this is when the seizure begins. And he makes those sort of groaning noises. Incidentally, when it's vocalization, like this should not be confused with ictal speech. Vocalizations like that are really not of any significant localizing value. They can come from either temporal lobe, frontal lobe seizures, so it doesn't mean a whole lot, that initial behavior there. Then he gets silent, sort of sits there. Now you can just start to see some pursing movements of his lips. See that? So it's classic temporal lobe seizure. The nurse walks in, you see as soon as he hears the door open, he regards her. So he turns to her and look. This is actually very common in temporal lobe seizures. People, this is why when we train the residents, we always say, you shouldn't ask them if they have a loss of consciousness, but rather an impairment of awareness. Because to a lot of people, you would say, well, this guy doesn't look unconscious. He responds, he interacts. He doesn't remember any of it, but he clearly regards the nurse and looks at her. As she asks him questions, you can see he's nodding his head, but it doesn't mean anything. He's not doing that in a sensible fashion. It's much like a stroke patient. So a patient who's aphasic, you talk to an aphasic patient, a lot of times they can tell that you're talking to them, and they just respond to everything sort of with a nod. And you can see he's still having this lip smacking. He's having a little dystonia of his hand there, so he's holding his hand kind of in a posture. So still lip smacking, still going on. And now it's winding down. So interesting, he's looking at her less now when he's post-ictal and just kind of confused. Oops. All right, so this is what his EEG shows. Okay, I don't know if this is super clear, but so this is a bipolar montage. So this is the left temporal chain, left parasagittal chain, midline chain, right parasagittal chain, right temporal chain. You can see here there's, this is sort of at the beginning of his clinical activity where he cries out, and this is a nice 5 Hertz rhythmic theta pattern that can be seen to be phase reversing around FT9. FT9 is right here at the base of the left temporal lobe. So this is a classic pattern for what we see with mesial onset temporal lobe epilepsy. And so you can see it's a beautiful rhythmic 5 Hertz pattern through here. It involves, rather widespread over the temporal lobe and extending a little bit into the frontal lobe. And then here it starts getting a little bit less rhythmic, but still pretty focal over here. And then now it starts breaking up further. And then really by the end of this page, it's over, and he's just postictal. So pretty straightforward. So now I want to show you some examples of some frontal lobe cases. This is a relatively straightforward one. I'll just play this for you. So this one actually goes on for a while, so I won't show you the whole thing, but let me show you a few things here as I play it again. So note that as I play it, the very first thing that happens is his lower lip extends towards the right. Okay, so this is a very focal onset seizure in the lower part of the motor strip. Oops. See, it goes out towards the right. It's kind of tonically deviated. Now he's into a little bit of hemiclonic movement, just in the face. It's staying quite focal. Note you don't see any jerking or anything of the hand. There's a little bit of tensing. So even without EEG, it's pretty clear where exactly this seizure is coming from because the area involved is so focal. So this would be coming from the posterior portion of the frontal lobe, the motor area, and has a pretty specific clinical semiology. Now this one is a little bit more complicated and starts further anterior and then spreads. All right, so let me go back and do that from the beginning. All right, so this seizure actually begins even a few seconds before the beginning of the video, but she doesn't do anything. So the seizure has actually already begun. And then you see she gets this funny look on her face. She kind of tilts her head up, very slowly turns towards the left. This is what we call versive head turning. It's not just a little bit of turning to one side, it's turning all the way around, almost like she's going to corkscrew. And then she assumes this, So I think what's happening here, and I'll show you the EEG in a minute, the seizures are starting from the right frontal lobe, right in about at this area between FP2 and F4. What I think is happening here is that the seizure is spreading and hitting from the anterior areas and spreading up into the mesial frontal area. And she's assuming here what we would call an asymmetric tonic posture, or asymmetric tonic position. So this often happens when the supplementary motor area is involved, which is the mesial frontal area, anterior to the motor strip, and they will often get bilateral involvement, but it will be asymmetric. The most classic presentation of that is what they call the fencer posture, where somebody looks like they're fencing. They can also have figure 4 posture, but it can have a great deal of variability, so it can look like anything, but those are two of the classic ones. So I think it's spreading to the supplementary motor area here, and then now you see it's starting to generalize. See, now it's becoming a little more symmetric. Her head is kind of pulling around to the center. So she's in the tonic phase. See, the legs are extended, the arms are flexed bilaterally. She's the midline now. Now you can see the side where it started on, the left arm, is now entering the clonic phase because the seizure has been going on longer on the right side of the brain. And it's still in the tonic phase here, even though she's in the clonic phase over here. Now the seizure activity in the right hemisphere is winding down, but still going strong in the left hemisphere. So this is what her EEG shows. I don't know how well this is showing up. So again, left temporal, left parasagittal, midline, right parasagittal, right temporal. And the EEG activity that is the most localizing here is that you see this high amplitude burst of polyspikes right here. It's maximal at FP2, which is right here, frontal polar, with a field that extends to F4 and FZ. So F4 is about here, and FZ is about here. And you can see there's these repetitive spikes. This is, again, about 4 or 5 seconds before even the beginning of the video that I showed you. It continues on. So it's going on for a long period of time up here frontally, and is pretty silent. So you don't really see anything at the beginning. And then probably somewhere in here, she starts to slowly head turn. Oops. Oh, sorry. Anyway, and then you can see here is where she starts to secondarily generalize. So the point in that is that when the seizure starts really far anteriorly in the frontal lobe, it may be silent at the very beginning of the seizure, and then you don't see any symptomatology until it spreads to some of the adjacent areas. Oops. So this is something we've all probably seen a lot of. Oops. He's hyperventilating. All right, let's go take a look at it again. We'll show you bit by bit. All right, so he's having induced hyperventilation here as part of our evaluation. And you see he was unresponsive briefly, and he pretty abruptly starts shaking. And the shaking is this rhythmic side-to-side shaking. As you see, notice how it involves mostly the trunk, less than the limbs, and involves the head, and it's side-to-side. See that? And it kind of involves his pelvis and his shoulders. It goes on, then all of a sudden it just stops. After it stops, he's unresponsive, even though his EEG at this time is stone cold normal waking alpha rhythm. So now, truth be told, during these spells, there's so much movement artifact. The EEG isn't all that helpful during the spell. I mean, the diagnosis of this really is made more by video because the movement artifact overwhelms the EEG. But one thing we can say electrophysiologically is that as soon as he stops, he has a completely normal EEG. It shows that he's awake and alert, even though his eyes are closed and he's unresponsive. So I think even in this case, there was electrophysiologic evidence that, that these were non-epileptic in nature. So all those are pretty routine things we see pretty regularly and are pretty easy. This is an interesting seizure. I want to know what you think about this. So in this young lady, her seizures began at age 25, about 1 year prior to presentation. She was seen by Robert Knowlton, who many of you know, and she was thought to be psychogenic, to have psychogenic non-epileptic seizures in clinic based on description of the spells. I was reading his initial consultation last night, and his exact wording was, clearly non-epileptic seizures, parentheses, psychogenic, versus much less likely epileptic seizures. So she's asleep.
Daddy, Seizure. Hello, what's your name? David what? And where are you? Okay, read this right here.
So a couple things to notice about that. We'll watch it again and I'll stop it. So she is asleep. She's completely asleep. Oh, and let me say this. So this is actually, even though we thought clinically, or that Dr. Knowlton thought clinically this might be psychogenic, this is actually a frontal lobe seizure. It's very unusual looking, but we see it we see these quite commonly, and they're easily mistaken for psychogenic non-epileptic spells. Frontal lobe seizures very often arise abruptly out of sleep. So it's one of the things to notice. So she's asleep. She gets this funny look on her face, and then begins these very bizarre movements. There's some side-to-side head shaking, but note that it's very arrhythmic and rather chaotic. Notice too that she kind of has at times this bilateral sort of strange postures.
Daddy, Seizure.
And then it's over. As soon as it's over, she's fully aware. They ask her what her name is.
Hello, what's your name?
She's able to tell him. And she's able to say where she is, that she's at the hospital, and she's able to read the card. So another thing that's classic for frontal lobe seizures like that. So we would call this a hypermotor frontal lobe seizure. Sometimes patients are even completely alert throughout the spell. They're characterized by no postictal symptomatology also. So this is another one that's another frontal lobe seizure. This young woman had seizures typically 1 to 3 per night and up to 6 seizures a day. It's another common finding in frontal lobe seizures is that they may have multiple seizures, multiple brief seizures throughout the day or throughout the night. She has no recollection of the event. Notice the scissoring kind of movement of her legs. And like the previous seizure, she has some chaotic flailing movements, but also has that blood-curdling scream, which really sounds very different than an ictal cry that people get with generalized tonic-clonic seizures. And people can very often yell and as though they're in pain, as though they're being attacked, as though they were just awoken from a scary dream. And you can see here then, oh, sorry, I can really get that. But she says she knows her name, she's able to talk. So as dramatic as it was, as soon as it's over, she is clear and able to interact. So in both of these cases, there was no obvious ictal pattern on the EEG. And almost all of the activity would have been obscured by movement anyway. But The interictal EEG in this case showed some questionable right frontal temporal slowing of uncertain clinical significance. She had also been told for a long time that she was non-epileptic, and these were thought to be just night terrors or panic attacks. And then we did an MRI, and it turns out she has a right mesial frontal cortical dysplasia. That was quite obvious once you looked for it. So again, a common presentation of frontal lobe seizures. Where in the frontal lobe these are coming from is a question of some debate. These can, part of why they're EEG negative is because when they're coming from the mesial frontal area or the orbital frontal area, they don't project well to the scalp. So the EEG signal isn't always detectable on the scalp. But in this case, clearly we could see a lesion. This is another gentleman who had a frontal lobe seizure. Again, you see this kind of chaotic, almost panicked look. And it's over. So this unfortunate guy, so this started when he was 31. He was 35 at the time of this. He had been told for years that these were psychogenic, and had actually been in therapy and for a long time. And it's funny because a lot of times when we see patients, we tell them that their episodes are psychogenic, and they get mad at us for telling them that they're psychogenic when they think that they're biological. And in fact, in this guy, he was like, "Are you kidding me? I've spent 4 years in therapy for this, and now you're telling me?" So I thought that was kind of interesting. But you can see that there are some similarities between these, but these are very different looking seizures, and they're very bizarre. He was fully conscious throughout his spells, had full recollection. He was also MRI negative. So how do we separate some of these? How do we separate these out? Frontal lobe seizures from psychogenic non-epileptic seizures. So there, these rules are not hard and fast. If they were, I wouldn't necessarily be in a job. But these are some of the principles to keep in mind. So psychogenic spells very often will start gradually or rapidly build up, while frontal lobe seizures often have an explosive onset. You saw the young woman who began by screaming and flailing her arms. Psychogenic spells are usually variable from one episode, from episode to episode, while frontal lobe seizures are highly stereotyped. The first one that I showed you, she had 6 seizures in the hospital that all looked exactly alike. As bizarre as they looked, they all looked exactly alike. The movements in psychogenic seizures will often significantly involve the torso or the pelvis. They may be sort of twisting, shimmying kind of movements. They may involve the shoulders as well. While in frontal lobe seizures, the movements are more appendicular. They're more extending their arms and flailing their arms. Postictally, psychogenic patients will often have decreased responsiveness. They may cry. While with these frontal lobe seizures, very often postictally, they're completely normal. They come right back to the normal self. Their affect is normal. They're not upset. They're just a little shaken. Psychogenic seizures often will be, the movements will be rhythmic or semi-rhythmic. The guy you saw at the beginning was doing that side-to-side shimmying, shaking thing. While in frontal lobe seizures, it's often arrhythmic or chaotic. Psychogenic seizures, the movements look like something you could mimic, while in frontal lobe seizures, the movements look just truly bizarre. And it's almost like the weirder it looks, the more likely it is to be frontal. And then lastly, psychogenic seizures, often their eyes are closed, while in frontal lobe seizures, their eyes are often open. All right, so this is another interesting seizure. This is a 43-year-old who has had spells a few times a year since the age of 16. And I'll just let you watch this and get your impression of it. So he feels funny, he's grunting, kind of extends his arms and his legs tonically. A little bit of jerking, grunting, heavy breathing, more extension. So he's starting to come around. It's still very out of it. So, and then in a second here, he's able to talk. So anybody want to venture a guess as to what that is? How would you describe those movements that he did initially? I think that's something that I've seen most frequently in the intensive care unit. So it looks like somebody who's posturing. And if we show his EEG, let me see here if I can make this happen. Oops. All right, so his EEG is kind of long, so I'm going to try to show it to you. Okay, hopefully this will work. All right, so this is his EEG at the very beginning. And it's basically normal. So right in here, I think he says he starts to feel bad. I can't see, yeah. So I think he says he starts to feel bad. At this point, he reaches up and covers his eyes. Afterwards, he's got a nice 9 hertz alpha rhythm, so he's fully conscious, but his eyes are closed here. Says he's not feeling good. By the way, each one of these little ticks is 1 second, each one of these lines. So it's about 8 or 10 seconds a page. Continues not feeling so good. Let me do this. Take out a little bit of low frequency stuff. Okay. So continues to not feel good, and then somewhere in here loses responsiveness. You see there's attenuation of his of the alpha activity in the background, and then here it starts getting very slow, very rapidly, and has just this high amplitude, diffuse delta activity. There's no ictal or no EEG, no epileptiform activity. And then here, this is when he's groaning and extending. So this is all just muscle artifact. But the EEG looks quite flat underneath that. Quite flat, continues now totally flat. Just a little bit of superimposed muscle artifact. Keeps going, keeps going. This is all movement stuff. This is a grunt. So no, very, very little cerebral activity. I think some of this is all movement-related stuff. Keeps going, keeps going. Now starts to get a little bit of low amplitude, very slow delta activity. Keeps going on. More delta activity, returning. More delta. Good higher amplitude delta, now looking a little bit more normal, now looking just like a moderate encephalopathy instead of a severe one. And then more of a mild encephalopathy with some theta slowing, keeps going, and then finally by the end, of this episode, it looks, I'll just scroll in, looks pretty normal. So he's got return of his 10 hertz alpha rhythm. So the interesting thing in this EEG is actually not the EEG. It's actually the EKG. So if you look down here, he's got, this is his, you can see his nice, can you guys see that? The EKG lead there? So he's got a, you know, he's going on at about 60 to 70 beats per minute. And this is where he starts getting symptomatic, starts feeling bad. You can see that space between the beats starts getting longer, and now it gets pretty long. He has this, I don't even think that's a beat. I think that's movement. And no heartbeat. Keeps going, keeps going. This is all movement artifact. Keeps going, keeps going. Maybe that's a beat. I don't think so. I think that's movement. Most of these little blips you see are associated with movement. So it keeps going, no heartbeat, no heartbeat, no heartbeat. What's that? What?
How is that possible?
He had a 90-second episode of asystole. And if you go back to the, let's see if we can go, well, I won't show you. At the very beginning, you could see the nurse was pulling away from his hand. She had just stuck his IV in. And he has so it turns out his spells that he's been having ever since he was 16 have all been induced by either being startled or some type of medical procedure, like getting stitches, getting a shot, getting an IV started, something like that. So this is vasopressor or vasodepressive convulsive syncope with asystole. So what's that? Was he hypoxic? Yes, that's exactly it. So this is cerebral ischemia. So he was posturing when he was doing those movements. He was posturing for the very same reason that that patients in the ICU will posture. So and he snapped back. This has happened to him. Sometimes he would go a few years without having an episode because they were all triggered. But sometimes it would happen a few times a year. So we you know, his first question, and he comes right back afterwards, and he seems to be back at baseline. His first question was, "Can I drive?" You know, and I'm like, so we got cardiology to come to see him. Cardiology saw him, and they recommended putting in a pacemaker. Since this had been so long, but he refused. He wasn't interested. He's like, I don't want to put anything in my body. I'm fine. I go years of these things. It only happens when you guys try to do something to me. So I told him this was not a great idea, but he. So last night I was reviewing his medical records to see what happened because he didn't have seizures, so I didn't follow him up. He ended up. I saw that back last August he finally decided to go ahead and get the pacemaker put in. So I think it was a good idea. Let me see if I can go back. And so that's something we actually see not uncommonly. Is people who come in with syncopal spells that are actually what we call convulsive syncope. That was the most dramatic example I think I've ever seen. More common examples look like this. Oops. How about this? So you can't really see, but again, off the screen here, she's getting an IV placed. Doesn't feel so good. Head's kind of bobbing, hands twitching there. A little bit of myoclonus, a little bit of myoclonus of the body. She slumps over. A little bit more twitching and jerking. So this is not real impressive. I think if you saw this happen at the dining room table, you may or may not call this a seizure. Interestingly enough, this is nothing like the spells that she came in for. She came in for spells of seeing some funny things, and but just happened to have this. So, and she comes back around pretty quickly. So I'll skip, in the interest of time, I'll skip showing you her seizures. So convulsive syncope. This is one of the more challenging things that we see, but we do see a good bit of it. Basically, what it is when you have some transient cerebral ischemia, it's very common to have some jerking or myoclonic type movements. I showed you a sort of a very dramatic case of it, and then a rather minor case of it. Back in 1994, there was a paper published by a German group where they did something. I don't know if we would be able to get this past our IRB here, but they took some 56 volunteers and actually induced syncope in them by having them hyperventilate. Then they had them on a tilt table, so they after they were hyperventilating for several minutes, they got them upright. Had them Valsalva, and they were able to produce syncope in 75% of the patients. 90% of those who had syncope had some kind of myoclonus, which is interesting. I didn't learn that in medical school, that you often have myoclonus of syncope. 52% actually fell stiffly with their legs extended. Myoclonic jerks were usually multifocal and non-rhythmic in 52% of the times. But many of them had multifocal jerks that were superimposed on top of generalized myoclonus in about 30% of the cases. So these things could easily be mistaken for seizures, particularly to the untrained eye. Facial muscles were even involved in 58% of the subjects. So additional motor activity, including non-forced lateral head turning, versive gaze deviation, and repetitive automatism, similar to seen in partial epileptic seizures, were seen in 79% of the episodes. And one patient even had tongue biting. How do we differentiate this? Because the EEG, or EKG, is often unremarkable. Another study showed that EKG provided a definitive diagnosis. This is a routine EKG, only 5% of the time. So most of the people interictally, if you will, are completely normal. But some of the key features that differentiate it from an epileptic event are that it's often preceded by the same sorts of things you would see with syncope. So they get dizzy, they get lightheaded, they feel faint, they feel nauseated. They will often pretty quickly come back and won't have a prolonged postictal state. All right, so moving on now to pharmacologic treatment of epilepsy, and I think I'm a little behind time here, so I'm going to try to go through this quickly. Oh, by the way, I forgot to mention when I first started, as far as my disclosures, I have nothing to disclose. I have an NIH K23 award looking at neuroimaging, but it doesn't pertain to any of the things that I'm talking about today. All right, so lots happened in the last several years regarding antiepileptic drugs. This is a little timeline of the history of modern antiepileptic therapy, or antiepileptic drug therapy. Back in 1918, phenobarbital came out. Prior to that, the main thing that was available were bromide salts. Phenytoin came out in 1937. These two were the main medications that were used for many, many years. There's a few other things that came out here, ethosuximide. And then things started picking up a little bit in the 70s with carbamazepine and valproate. But then there was a good stretch of time here when there were no other antiepileptic medications that came out. And then as a result of some of the efforts that were started in an investigative compound program in the 70s or 80s, in the 90s we then got an explosion of new antiepileptic drugs, starting with felbamate, and as you can see going up here, there's a few others that I left out. But it's made things rather complicated then in a few years, over the last few years. Up until 10 or 20 years ago, epilepsy medication management was relatively simple, if not easy. But it's now become somewhat confusing with so many different things available, and that's consequently produced a shift in paradigms. So I'm just going to go over some of those paradigms and talk a little bit about some of the newer drugs that have come out. So one of the probably the most prominent shifting paradigm is what do we use as first-line agents? Even when I was in training 10 years ago, carbamazepine was still considered kind of the reference standard for treatment of partial onset epilepsies. Many of the patients we saw, routinely they come into the emergency room with their first seizure and get started on phenytoin or Dilantin. Everybody who had primary generalized epilepsy was treated with valproate. And there were still plenty of folks getting put on phenobarbital. But that has really shifted now towards the newer drugs being the standard of care, at least among epileptologists, and I think general neurologists as well, and even the ER physicians now. So it went from being everybody getting put on phenytoin in the emergency room when they come in to everybody being put on Keppra. And several of these drugs even have monotherapy indications, if not initial monotherapy indications. But I can't remember the last time I started somebody initially on one of these agents, unless they really couldn't afford it. But then again, cost really is now not nearly as much of an issue either. The old paradigm was that the older drugs were reasonably priced and affordable, and insurance would pay for them, but the newer drugs were very, very expensive. But now, since the newer drugs are available in a generic form, they're really quite affordable. So you can see brand name Dilantin, which was one of the dogma that we had to have brand name medications, is $54 for about a month's supply. Generic is $16. Well, it's actually more expensive in a generic form than Lamictal is, or Topamax, and about the same as, and only a little bit less than Keppra. So this really does represent a significant paradigm shift. You can see how these things are, quite expensive, but the generic versions of these medications are really quite affordable. Another, then big shift in paradigms is that the former dogma was that generics are, no generics. Generics were anathema. And part of that had to do with some of the peculiarities of Dilantin, that was the most commonly used drug. That was an easier thing to get away with when the name brand drugs were not that expensive. But now that we have the newer generation drugs available in a generic form, and the fact that the FDA insists that these are bioequivalent, it's harder to get away with getting brand name drugs or to even justify that. All of the major organizations, American Epilepsy Society, the American Academy of Neurology, the Epilepsy Foundation of America, and the International League Against Epilepsy, recognize that there's insufficient evidence currently to conclude one way or the other, whether generics or name brand drugs are better. I think our common experience was that the name brand drugs are good, and we probably all had patients who were switched from name brand to generic and had some type of problem or had a breakthrough seizure. But whether or not that seizure would have happened if they'd stayed on brand name is hard to know. Nowadays, too, regardless of what we think about whether a patient should or shouldn't have a generic or a name brand, Medicare and Medicaid are really forcing our hand, and rarely will allow a name brand medication if generic drugs are available, unless there's clear documentations of seizure on generic. And even then, a lot of times with Medicare, you can't get the drug approved. Private insurers more and more are routinely requiring patients to pay the difference for a name brand drug, which, when you're talking about the difference between a $40 or $20 generic and a $400 name brand, that's a pretty big difference. Not many of us in the room would want to pay that. So what is this issue that, with bioequivalence? The FDA insists that generics are bioequivalent. This can be a little bit confusing, but to explain it a little bit, there's two different things that they look at for bioequivalence. When a name brand drug comes out, they have to extensively prove that the drug works in 3 trials. But when a generic comes out, they don't have to prove that it works. They just have to prove that it's bioequivalent to the name brand drug. There's 2 parameters that they really look at. One is the peak drug level. So if you look at this plot and see that it's this is the serum concentration on the y-axis over time. After a period of time, the drug peaks and then it's gradually eliminated. They look at the peak level and the area under the curve. So if you can see these 2 drugs here, the question could be posed, is drug A, or are drug A and drug B bioequivalent? They're certainly very close, but are they equivalent? And the way the FDA determines this is they look at the reference drug, the branded drug, and compare the among the study population or the study sample, what is the mean area under the curve or the maximum concentration? How does that compare to the name brand drug? And they are considered to be bioequivalent if the 90% confidence interval is between 80% and 125% of the branded drug. Now, I want to be clear here. Some people will say that it's considered equivalent if it's anywhere between 80 and 125%. It's a little more stringent than that. It's the 90% confidence interval, which often is a good bit wider, and you know, if the 90% confidence interval is between those bounds, then the actual mean will usually be within 4% of the branded drug. However, theoretically, it is possible to have one with a very narrow confidence intervals that is 10% or more lower or 10% or more higher. However, these tests are done under very controlled circumstances in an idealized population. They're all done on healthy controls, on an empty stomach. They're not done on epilepsy patients. They're not done in real world situations. They don't look at the effect of food. They don't look at chronic dosing. They don't look at the Tmax, which is the time to peak. And they don't consider the inactive agents in the pills that theoretically could cause side effects. They also don't look at individual patient variability. So there's a study that we are going to be...
I have to ask you to wrap up pretty quick here.
Okay.
In fairness to the other speakers, so.
Okay, thank you. So I'll just tell you a little bit about this, and then we'll bring it in for a close. So we are going to be participating in something called the Equigen study, and which is looking at the equivalency of different generic drugs, or of two different generic versions of Lamictal. This will be more of a real-life type of study, looking at where the medications will be tested in epilepsy patients. We're looking both at chronic use of the drug and a single dose of the drug. What will happen in the chronic arm is that patients will alternate between two different generic forms every 2 weeks. In the single dose arm, patients will get a single dose of either the brand name Lamictal, generic 1 or generic 2. Lamictal was chosen because it's the one that's been shown to have the most variability in the generic doses. The primary outcome is to determine if there is a significant difference between the two generic forms of Lamictal, or lamotrigine, and the brand name Lamictal, i.e. are they bioequivalent? Secondary outcome is to determine if there's a difference in the level when checked at different times. So instead of just checking one time point, patients switch from one generic to another generic and back and forth. Other outcomes that they hope to look at is to determine whether or not there's a subset of patients in whom drugs are not bioequivalent and what makes those individuals different. They also want to determine if there's a difference in bioequivalence among patients who are on enzyme-inducing antiepileptic drugs and those who are not. Also, they want to look specifically, is there a difference between males and females, and what role does difference in metabolism and hormones play in that? And then also want to compare whether or not the bioequivalence between generics and patients who had a loss of seizure control or new side effects was different from the other group. All right, so with that, I will wind up and pass the baton on to Jerzy Saflarski.